All right, let's jump right in. Today, we're tackling one of the most demanding situations we face in our specialty, the anesthetic management of preeclampsia and eclampsia for a cesarean section. This isn't just about putting a patient to sleep. It's about being a true perioperative physician, steering our patient and her baby safely through an absolute multi-system storm. I wanted to start with that because it's the truth. The work you do in these high-stakes situations requires incredible focus, skill, and vigilance. It's a true test of our understanding of a really complex disease. So let's honor that dedication and dive deep into the knowledge that lets us provide the safest care possible. So here's how we're going to break it all down today. We'll start with the core problem, what I'm calling the systemic vascular storm. Then we'll talk about everything we need to do to stabilize the patient before anesthesia. After that, we hit the big one, the central decision of which anesthetic to use. We'll then look at the hard evidence for spinal anesthesia and bust some old myths. And finally, we'll cover what happens after delivery and the long-term risks you need to have on your radar. Okay, let's get into it. Part 1, the systemic vascular storm. You see, to manage this thing, you can't just treat the symptoms. You have to understand the why behind it all. It all starts from one single problem that then just explodes through the patient's entire body. So what is this beast we're dealing with? At its core, preeclampsia is a multi-system disorder that pops up after 20 weeks of pregnancy. The classic signs we all know are brand new hypertension and protein in the urine. But the key is that it affects up to 7% of all pregnancies. I mean, think about that. It's a major player in maternal and neonatal morbidity and mortality across the globe, which is exactly why our role is so incredibly vital. This slide right here, this gets to the absolute heart of the matter. The root cause of preeclampsia is widespread damage to the endothelium, that thin inner lining of every single blood vessel in the body. The whole disaster starts with a dysfunctional placenta, which creates this high-resistance, low-flow state. That unhappy placenta then releases a cocktail of nasty factors into the mom's circulation that literally poisons the endothelium everywhere. Every single clinical sign we see is just a downstream effect of this initial hit. And this table just lays it all out so clearly. It shows exactly how that endothelial damage cooks up the clinical picture we see. So let's walk through it. First, you get intense vasoconstriction. The whole system is out of balance, leading to a massive increase in systemic vascular resistance. And what do we see at the bedside? Severe hypertension. Second, the blood vessels get leaky. That damaged endothelium can't hold things in anymore, so plasma and proteins spill out into the tissues. That gives you the proteinuria and the edema. But here's the absolute central dilemma for us. It means their intravascular volume is low. The patient is swollen everywhere, but intravascularly, she's dry. And third, you see the hematologic changes. Platelets get chewed up at all these sites of damage, which leads directly to thrombocytopenia. Okay, so that brings us to part 2, pre-anesthetic stabilization. Our job here starts long before that patient ever rolls into the operating room. As perioperative physicians, our first mission is to get this vascular storm under control and make the patient as safe as possible for what's to come. Job number 1, without a doubt, is seizure prophylaxis. The jump from preeclampsia to eclampsia, which is when seizures start, is a catastrophic event we have to prevent at all costs. And when it comes to that, there is no debate. The drug of choice, hands down, is magnesium sulfate. As you can see here, you've basically got 2 main ways to give it, the all-IV Zuspan regimen or the combination IV/IM Pritchard regimen. The goal is the same for both, get that therapeutic level up to stop a devastating seizure. Now, this is the part we absolutely have to get right. Magnesium has a super narrow therapeutic window. We're aiming for a sweet spot between 4 and 7 milliequivalents per liter. Go above that and toxicity shows up fast. The first sign, the one you can check at the bedside, is the loss of deep tendon reflexes. That happens around 10 milliequivalents per liter. That is your canary in the coal mine. If the level keeps climbing, you're risking respiratory depression and even cardiac arrest. This is why you have to be constantly assessing the patient. And you better believe you need the antidote, calcium gluconate, right there, ready to go. Okay, next up, that blood pressure. We have got to wrestle it under control because stroke is a very real, very scary risk here. Usually, once we see a sustained systolic over 160 or a diastolic over 110, it's time to act. As the table shows, labetalol is often our go-to. It's great because it lowers blood pressure without that nasty reflex tachycardia. Hydralazine works too. It's a reliable old friend, but it can be a bit slower and might cause that tachycardia. Nifedipine is a good oral option if you need it, but just remember, we never give it sublingually. The risk of a sudden catastrophic drop in blood pressure is just too high. And all of this brings us back to that crazy fluid paradox we talked about. Because of that leaky endothelium, These patients are walking a tightrope over a massive chasm of pulmonary edema. Any excess fluid we give them is just going to pour right into their lungs. So if you go in and just blast them with crystalloid, you are asking for big trouble. Our guiding principle has to be strict, judicious fluid restriction. A good target to aim for, including all your drips and maintenance, is somewhere around 80 mL an hour. It is a constant, delicate balancing act. So, we've got the patient stabilized, we've got the magnesium on board, the blood pressure is under better control, and we're being careful with fluids. Now we come to part 3, the anesthesia decision. This choice for the C-section is a huge fork in the road. And what's really interesting here is seeing how our practice has totally evolved, moving away from old fears and towards solid new evidence.
This is it, the fundamental question. For this patient, with her sky-high blood pressure, her swollen airway, her potentially low platelets, and her tricky volume status, what is the safest path forward? Do we go with regional anesthesia, or do we go with a general?
Man, this table just says it all, doesn't it? Look at the risks of general anesthesia. The airway is a nightmare waiting to happen. That systemic edema often means airway edema, which sends the risk of a can't intubate, can't ventilate scenario through the roof. Then there's the hypertensive crisis when you intubate. Laryngoscopy can trigger this massive catecholamine surge, which could cause a stroke right there on the table. And on top of all that, you lose your best neurological monitor, the patient. Now, compare that to regional. You avoid the airway completely, you get beautiful, stable hemodynamics because you're blunting that stress response. And critically, your patient is awake, so you have continuous neurological monitoring. For all these reasons, regional anesthesia is, without a doubt, powerfully preferred whenever it's an option.
Okay, so we've established that regional is the way to go if we can. That brings us to part 4, and this is where we get to bust a big old myth about spinal anesthesia. For decades, people were terrified to do spinals on these patients. The thinking was that the rapid sympathectomy would cause a catastrophic drop in blood pressure in someone who was already volume down. But as it turns out, modern evidence tells a completely different story.
This single statement right here, this changed everything. The old fear was that a spinal would just make their blood pressure crash, but the research has actually shown the opposite is often true. Think about it. Their vascular system is already so intensely vasoconstricted, so clamped down, that they're actually less sensitive to the sympathectomy from the spinal block. More often than not, they have a smaller, more controllable drop in blood pressure than a perfectly healthy patient would. So, where's the proof? Well, it's right here in this landmark trial from Vasiliya Putra and his colleagues. They did the study we all wanted to see, a head-to-head comparison of spinal versus epidural anesthesia in patients with severe preeclampsia. The results were fascinating. Yeah, the spinal group did have a statistically higher incidence of hypotension, but, and this is the crucial part, that hypotension was clinically insignificant. We're talking about a median duration of less than a minute, easily treated with tiny doses of pressors. And most importantly, there was absolutely no difference in how the babies did. This study was a total game changer. It gave us solid evidence that spinal is a safe, fast, and reliable choice for these patients. All right, the surgery's over, the baby's out. But listen, our job is not done. Not by a long shot. This brings us to our final section, part 5, delivery of the placenta. Is the treatment? Yes, but it is not an instant cure. The postpartum period demands our continued and even heightened vigilance. So what are our marching orders post-op? 3 non-negotiables. First, intensive monitoring has to continue for at least 48 hours, preferably in a high-dependency unit. Second, that magnesium infusion keeps running for at least 24 hours after delivery to prevent those scary late-onset seizures. And third, and I cannot say this enough, we have to stay incredibly cautious with fluids. After delivery, this massive fluid shift happens where all that third-spaced fluid starts pouring back into the circulation. This is a peak danger time for pulmonary edema. We have to keep restricting fluids. So let's wrap this up with something that I think is really important for all of us to remember. Our time with this patient might just be a few hours, but the diagnosis she carries has lifelong implications. Preeclampsia isn't just some random pregnancy problem. It's a stress test that unmasks a woman's predisposition to future cardiovascular disease. These patients have a much higher lifetime risk of chronic hypertension, heart disease, and stroke. The expert care we provide today is just one critical moment in a much longer story. By getting them safely through this crisis, we're not just ensuring a healthy mom and baby today, we're also marking the start of a new chapter in their long-term health. Our vigilance matters, not just for this admission, but for all of their tomorrows.